Welcome to the debate. Imagine for a second that you are a pilot, but you only get to fly the simulator once a year for maybe a few hours at most.
Right. And then what?
Then, one night, you are suddenly asked to land a commercial jet in a Category 5 hurricane, in the dark, with all the alarms screaming. I mean, the theory of how to fly that plane might be totally sound, but the operational reality of attempting that landing, it's going to be deadly.
Well, that is exactly what we ask paramedics to do every single day.
Exactly, and that is the absolute core of our discussion today. We're looking at a fundamental crisis in out-of-hospital cardiac arrest. When someone's heart stops in their living room or on the sidewalk. For decades, the absolute gold standard for paramedics was to secure the airway using endotracheal intubation.
Right. Using a metal blade to lift the tongue and sliding a plastic tube directly through the vocal cords into the windpipe.
Right.
Because it is the definitive airway. I mean, it isolates the lungs, protects them, and ensures oxygen actually gets where it needs to go.
Sure, theoretically, but a massive body of recent evidence is challenging whether paramedics should still be attempting this in the field at all. I'll be taking the position that, frankly, endotracheal intubation needs to be phased out as a standard universal paramedic skill.
Wow, phased out completely?
Yes, in favor of relying entirely on supraglottic airway devices, which are essentially masks that just sit on top of the vocal cords rather than passing through them. The data shows intubation offers no overall survival benefit, the complication rates are staggering, and, well, it has just become mathematically impossible for paramedics to maintain proficiency.
And I will, of course, be taking the opposing view here. Endotracheal intubation remains an irreplaceable, critical medical intervention. Yes, the data shows massive logistical challenges. I won't deny that.
Good, because they're undeniable.
But those challenges are most pronounced in patients with severely compromised airways, which is exactly where those alternative devices fundamentally fail. My position is that the EMS system has a moral and clinical obligation to solve this training deficit. We cannot just abandon a life-saving tool simply because it's difficult to maintain.
Okay, well, let's start with the macro-level evidence, because we have to ground this in actual patient outcomes. Survival for out-of-hospital cardiac arrest is already dismal. I mean, we are talking about less than 1 in 10 patients surviving to hospital discharge.
Sadly, yes.
Right. So the medical community conducted the Airways 2 trial. It was this massive, landmark randomized trial designed specifically to answer this question. Does the classic plastic tube through the vocal cords actually save more lives than a supraglottic device, specifically one called the iGel?
And I think it's important to quickly note how the iGel works compared to the tube.
Yeah, absolutely. Think of the iGel like a plunger sitting over a drain. It just rests over the airway opening and forms a seal.
Right.
Whereas the endotracheal tube is more like a cork shoved directly into the neck of a bottle, complete with a little balloon that inflates to lock it in place.
Which is a crucial mechanical difference we will absolutely need to unpack.
We will. But first, look at the trial results. The findings were totally unambiguous. There was absolutely zero significant difference in functional outcome at hospital discharge at 30 days, at 3 months, or 6 months between the tube group and the iGel group.
The trial was definitely eye-opening, yeah.
The tube didn't save more lives, period. And the reason, frankly, is a massive systemic training failure. Historical data shows paramedics average only about 3.7 intubations a year.
Which is, far below the 15 to 20 required for basic proficiency.
Vastly below. In fact, prehospital intubation has even been associated with increased mortality in patients with severe traumatic brain injury. Look, the core issue is that failure to ventilate a patient, failure to get oxygen in and carbon dioxide out, is substandard care. Failure to intubate is not.
Right, but
the iGel provides that essential ventilation without the risks of accidentally putting the tube down the esophagus into the stomach. Which historically happened, up to 25% of the time in some older studies?
Look, I don't disagree that supraglottic airways like the iGel are incredibly effective for a large portion of the population. They absolutely have a vital place in pre-hospital care. But looking only at the broad primary outcomes of a trial like Airways 2 completely obscures the brutal physiological reality of the pre-hospital environment.
How so? If the primary outcome is did the patient survive? Shouldn't that be the only metric that truly matters?
Well, not when you look at why certain devices fail on the ground. When you dive into the clinical nuance, specifically a follow-up study called Pearl, a very different picture emerges.
The protocol deviation study?
Exactly. PARLNI analyzed the protocol deviations during the Airways 2 trial. Essentially, it looked at the moments where paramedics were told to use one device by the trial protocol, but the reality on the ground forced them to abandon it and switch.
Right. Paramedics didn't follow their allocated airway algorithm in about 11.7% of cases.
Yes, but why did they deviate? This is the most crucial piece of evidence in this entire debate. When paramedics in the iGel group deviated from their protocol, almost 40% of the time it was because of an obstructed, fluid-filled, or bloody airway. Remember your analogy?
The plunger.
The plunger sitting over a drain. Exactly. It does not perfectly seal the trachea. A cuffed endotracheal tube, the cork in the bottle, does.
Cardiac arrest is a messy event, sure.
It's incredibly violent. Emesis or vomiting occurs in roughly 32% of cardiac arrest. The chest compressions themselves are literally squeezing the stomach and pushing gastric contents up the esophagus. If you just have a plunger sitting over the airway, it fundamentally fails to protect the lungs against aspiration.
I see why you think that, but let me give you a different perspective.
We are talking about vomit flooding the lungs. The 2021 resuscitation guidelines de-emphasized intubation, and in doing so, they created a deeply dangerous gap in care for almost a third of our patients who have a soiled airway.
Wait, but let's unpack that. Even if we completely accept that the iGel is vulnerable to fluid, and mechanically it is, I concede that, we cannot ignore the final calculus of the trial.
Which was based on aggregates.
But despite that high deviation rate for fluids in the iGel group, the overall Airways 2 data still showed no survival benefit for the intubation group.
Because, as I said, trials look at aggregates. They don't look at the individual catastrophe in the back of the ambulance.
But think about what that aggregate actually means. If protecting the airway from vomit with a perfect cork was so statistically vital to survival, the intubation group should have cleanly won the trial. I mean, the math should heavily favor the tube.
Not necessarily. If
The fact that it didn't means the theoretical protection of the endotracheal tube is being entirely wiped out by the practical harms of attempting to place it. We are trading the risk of aspiration for the certainty of interrupted CPR.
I come at it from a different way. A trial's primary outcome across thousands of patients doesn't invalidate the specific catastrophic device failures occurring on the ground. You can't just tell a paramedic staring down a fluid-filled throat that the statistics balance out in the aggregate.
So what are the paramedics actually experiencing in those moments?
Well, the Pearl study documented the free text responses from the clinicians actually doing the work. One paramedic reported that the iGel was literally, and I quote, spraying vomit across the trolley and clogging up.
Wow.
Yeah. Another noted they had to switch to intubation strictly due to the massive amount of fluid. When chest compressions are pushing gastric contents up, an iGel doesn't just fail to seal, it can actively become a funnel directing that fluid right into the lungs. In those highly critical moments, the supraglottic airway isn't just suboptimal, it is functionally useless.
But what is the alternative?
The alternative is the endotracheal tube. I mean, if we remove intubation from the standard paramedic scope of practice, what exactly is the backup plan when the iGel is literally spraying vomit across the ambulance?
The backup plan is basic airway management, suctioning the airway using basic face masks and prioritizing continuous chest compressions. Because the alternative you're defending is mechanically failing just as often, but for totally different reasons.
Intubation secures the airway. It doesn't fail if the provider is trained.
But the data says otherwise. You brought up the deviations in the PRL study for the iGel group. Let's look at the intubation group's deviations. Nearly 1 in 5 of the intubation deviations were due to a lack of space or positioning issues. The patient was, trapped in a bathroom or wedged between a bed and a wall.
Which are difficult environments. Yes, I'll give you that.
And another chunk was due to simply having a poor view of the vocal cords.
Well, yeah.
But it's worse than just difficult. In that subgroup with space issues, 100% of those patients died by 30 days. When 16.3% of intubation deviations were due to lack of space, and poor view issues literally plagued the procedure, isn't the pursuit of a perfectly secured airway actually causing fatal interruptions to chest compressions? You're struggling for minutes to get a good look at the cords?
It doesn't require perfect conditions, though. It requires an operator who knows how to optimize the anatomy.
You have to lay the patient flat, extend their neck, get a perfectly clear line of sight, and thread a tube while someone else stops doing chest compressions?
It causes interruptions if the provider is not proficient. And that, frankly, brings us exactly to the core of the issue. We aren't really debating the physiological superiority of the tube. We both agree that an inflated cuff below the vocal cords, the cork in the bottle, is the definitive airway.
Mechanically, sure.
Right. The debate is whether it's possible for the modern paramedic to perform it correctly given current constraints.
And the evidence overwhelmingly says it is not possible.
I argue it is possible, but the medical system has just stopped trying to support them.
We haven't stopped trying. The entire medical landscape has fundamentally shifted beneath our feet. This isn't about paramedics being lazy or systems giving up. This is about total collapse in training infrastructure. Let's look at the data from the Journal of Emergency Medical Services, or JEMS. Historically, how did a paramedic student learn to intubate a living human being?
Well, they learned in the hospital operating room under the controlled supervision of an anesthesiologist.
Exactly. But that access has absolutely plummeted. It's the death knell of the procedure. Many paramedic programs today are offering less than 16 hours of total operating room training per student. Do you know why?
Sure, because hospitals themselves are using more supraglottic airways for routine surgeries.
Right. Anesthesiologists realize that for a 30-minute knee surgery, they don't need a deep tube. They can just use a laryngeal mask.
There are fewer tubes being placed in the OR. Yes.
So there are fewer opportunities to practice. Furthermore, a paramedic student in that operating room is competing with anesthesia residents, respiratory therapy students, and critical care fellows for the few tubes that are actually left.
I understand the bottleneck.
And this translates directly to a crisis on the street. Look at the Maine EMS white paper, which did a massive dive into their state's data. Intubation attempts dropped 57% from 2009 to 2015. In a given year, only 1 in 4 eligible paramedics even attempted the procedure in the field.
Which is a systemic failure of the medical directors, not the procedure itself.
You cannot mandate a high-acuity, high-risk psychomotor skill when the providers have literally zero opportunity to practice it on living human beings. It borders on systemic negligence to hand a paramedic a metal blade and say, go do this incredibly difficult thing you haven't done on a living person in 3 years.
That's a compelling argument, but have you considered that the very same Maine EMS white paper you are citing provides the exact roadmap to save the skill?
I mean, they proposed ideas, sure.
They didn't conclude we should just discard intubation. The medical directors and system leaders explicitly stated that intubation must remain an option.
But their solutions are logistically impossible for most agencies.
Their solution is to not throw our hands up and say, well, the ORs are busy, let's just use iGels. They insist that system leaders build regular airway management practice into their schedules with comprehensive QI programs. Yes, clinical exposure is down, but we have high-fidelity human-patient simulators now.
Mannequins are not humans.
These are incredibly advanced mannequins that react physiologically. They have pulses, their pupils dilate, their airways swell. We have clinical remediation pathways. If a system doesn't have enough field intubations to support all its paramedics, the main paper suggests aggressively rotating those paramedics through simulation labs to maintain proficiency.
It's just not enough.
We cannot lower the standard of clinical care for our most critical patients just because scheduling simulation time is logistically annoying.
It isn't just annoying, it's a mathematical impossibility for modern EMS. Let's do the math on those recommendations. The American Heart Association recommends 6 to 12 intubations a year just to remain credentialed.
Right.
And successful systems that boast high success rates, they require a minimum of 15 live intubations per provider per year.
Which is what we should aim for.
But how? Take a rural EMS service in Maine or Texas, or a volunteer squad in the Midwest. Call volumes are naturally lower. How can a realistic medical director guarantee 15 live practice opportunities for every single paramedic on a 50-person roster without risking patient safety on the learning curve? They can't. And if you rely entirely on plastic mannequins to make up the difference, you are risking lives.
High-fidelity simulation is proven to bridge psychomotor gaps in surgery and aviation. Why not EMS?
Because a plastic mannequin doesn't accurately replicate trismus, where a patient's jaw muscles violently spasm and lock shut. A mannequin doesn't replicate a severely obese patient trapped in the bathroom between a toilet and a bathtub covered in bodily fluids.
Simulation doesn't have to be perfect, though.
You cannot perfectly simulate the environmental chaos of an airway caked in vomit while the patient's family is screaming at you. When that provider encounters a real, bloody, swollen human airway, the plastic mannequin training falls apart.
It has to be part of a comprehensive matrix. And this is exactly where technology is stepping in to bridge the gap between the undeniable need for definitive airway and the lack of frequent human practice. Have you considered the impact of video laryngoscopy?
You mean putting a camera on the blade?
Exactly. Devices like the GlideScope Ranger put a high-definition camera right at the tip of the intubation blade. It completely changes the geometry of the procedure.
How so? Explain the difference for the provider.
Okay, with traditional direct laryngoscopy, just a metal blade and a tiny light bulb, you have to physically manipulate the patient's head and neck to align the oral, pharyngeal, and laryngeal axes.
Right.
You are basically trying to make a straight, physical line of sight from outside their mouth all the way down their throat to their vocal cords. It's incredibly difficult.
And video changes that?
Completely. Because the camera is at the tip of the blade, you don't need a straight line of sight. You look at a screen. The camera sees around the curve of the tongue for you. The main EMS pilot project specifically looked at this. Video laryngoscopy drastically decreases the complexity of intubation. It dramatically improves first-pass success rates, and it flattens the learning curve. This technology makes intubation viable again for the general paramedic. It effectively neutralizes your argument that the skill is too difficult to maintain.
I completely disagree. In fact, that technology actually introduces incredibly dangerous false confidence. The main EMS white paper explicitly warns against exactly what you're suggesting. Their absolute clearest takeaway from that video laryngoscopy pilot program was this phrase: "It is not the tool, but your talent."
Well, a better tool amplifies talent.
But a video screen does not fix a fundamental lack of clinical decision-making. Staring at a screen doesn't tell a paramedic when they need to pause CPR or how to properly pre-oxygenate a patient before they make the attempt. Furthermore, let's look at the actual protocol requirements Maine established for these video devices. They demand that the blades use standard geometry, not hyperangulated geometry.
Right, maybe explain the difference there.
Hyperangulated blades have a severe sharp curve to them. They sweep around the tongue easily, but passing the tube through them requires a rigid stylet and a totally different technique. Standard geometry blades, on the other hand, have the exact same gentle curve as the traditional metal blades paramedics have used for 50 years. Maine requires standard geometry.
Which is a feature. It means the provider can use the blade for traditional direct visualization if the camera fails.
Exactly. But think about what that implies. Because it has to be standard geometry, the provider still needs the exact same fine motor skills, the exact same wrist mechanics, and the exact same physical lifting technique as traditional intubation. You haven't bypassed the psychomotor requirement at all. You've literally just glued a TV screen to it.
Seeing the anatomy clearly is half the battle.
But the muscle memory is the other half. Believing a video screen fixes a lack of psychomotor practice is like believing buying an expensive camera automatically makes you a professional photographer. You still need to know how to frame the shot.
But?
And worse, if the battery dies, which the text notes explicitly happens mid-arrest, the provider is left holding a piece of plastic, forced to perform a highly complex motor skill they haven't practiced in years.
But equipment redundancy is standard in any medical procedure. The fact that a battery might die is not a clinical argument against the efficacy of the intervention. I mean, a defibrillator battery can die. We don't abandon electricity for cardiac arrest.
A defibrillator doesn't require you to pause chest compressions for a minute while you fiddle with it.
The addition of video drastically improves the view in the 80 to 90% of cases where the battery is fully charged. Returning to the anatomy, we know there are predictors for difficult airways: obesity, short, thick necks, limited neck extension. Video specifically mitigates those exact anatomical challenges that lead to the poor view protocol deviations you cited earlier. By rejecting this technology and pushing universally for supraglottic airways, you are willingly blinding paramedics.
I'm not blinding them,
You are taking away a tool that allows them to objectively confirm placement by seeing the tube pass through the cords on a high-definition screen.
But you are isolating the airway from the rest of the resuscitation. The heart doesn't just need an airway, it needs oxygenated blood circulating, which means it needs uninterrupted chest compressions. Let's talk about coronary perfusion pressure.
Right, the pressure driving blood into the heart muscle itself.
Exactly. When you do chest compressions, it takes several pushes just to build up enough pressure to force blood into the coronary arteries to feed the dying heart. The moment you stop pushing, that pressure instantly drops to zero.
Which is why we minimize pauses.
But intubation maximizes them. When a paramedic places an I-gel, the median insertion time is incredibly fast. It's often well under 15 seconds, and it rarely requires pausing chest compressions at all. You just slide it in while someone is pushing on the chest. An intubation attempt, even with video, almost always requires pausing compressions.
Briefly.
Sometimes repeatedly. Every single second you are off the chest staring at a screen, coronary perfusion pressure is zero. The heart is dying faster.
You're assuming the supraglottic is actually ventilating the lungs, though.
That is exactly why the Airways 2 trial found what it found. The theoretically perfect, definitive airway achieved by the tube is completely offset by the damage done to the brain and the heart during the time it took to place it. We are literally killing the patient to save the airway. In out-of-hospital medicine, perfection is the enemy of survival. We have to treat the clock, not just the anatomy.
Perfection isn't what we are asking for. We are asking for clinical completeness. And clinical completeness means addressing the roughly 32% of patients whose airways fill with vomit and blood. A 15-second insertion time for an I-gel is entirely meaningless if the device is immediately overwhelmed by emesis.
It handles minor secretions fine.
It renders ventilation impossible in heavy emesis. It causes massive aspiration into the lungs. If you cannot ventilate the patient because the I-gel is clogged, your perfect uninterrupted chest compressions are just circulating deoxygenated acidic blood.
This is exactly why we need to view the system as a whole, rather than focusing on individual device failures.
But the system is made up of individual patients dying from aspiration.
I hear you, I really do. But the reality of the street is brutal. We have decreasing opportunities for live practice. We have dropping success rates. We have a massive risk of fatal interruptions to CPR. Supraglottic devices like the I-gel are not perfect. They certainly have major flaws, particularly in those heavily soiled airways, as the Pearl study rightly highlighted.
Right.
But public health and EMS systems design are about providing the greatest overall good to the greatest number of patients.
Even at the expense of the minority who genuinely need the tube?
We have to play the odds. Supraglottic airways require significantly less training to master. They cause fewer interruptions to vital CPR, and ultimately, as the largest randomized controlled trial on the subject demonstrated, they yield identical long-term functional outcomes for patients across the board. We simply cannot build a universal EMS system around the rare perfection of a procedure that most providers can no longer maintain.
And I maintain that the human body's sheer unpredictability demands more than a one-size-fits-all approach based on statistical averages. The high rate of regurgitation during cardiac arrest is not a minor edge case we can just write off.
No one is writing it off.
It is a fundamental physiological reality of doing CPR on a human being with a full stomach. The fact that an I-gel cannot protect the lungs from gastric content means that paramedics must retain the ability to secure a definitive airway with an endotracheal tube. De-emphasizing this skill represents a deeply dangerous concession to logistical convenience over clinical necessity.
It's not convenience, it's reality.
If the training is failing, we must fix the training. We mandate rigorous simulation, we demand aggressive quality improvement from medical directors, and we implement video technology to bridge the anatomical gaps. We do not adapt to a failing training system by lowering our clinical standards. We must elevate the system to meet the physiological needs of the patient.
I think what this debate really highlights is the agonizing choice medical directors are being forced to make right now. There is no perfect answer here. You are either choosing to maintain a failing psychomotor skill that might occasionally save a soiled airway, or you are choosing a faster, safer device that occasionally fails catastrophically.
It is an intensely difficult position. We are asking clinicians to perform highly complex procedures in the back of moving vehicles, in cramped living rooms, often as a solo responder until backup arrives. The environment is completely unforgiving.
And the stakes couldn't be higher. We both agree that the true enemy here is the failure to ventilate the patient, regardless of the tool used. An unrecognized esophageal intubation with the tube is fatal, just as an eye gel completely clogged with vomit is fatal.
Exactly. A single device likely cannot seamlessly cover every physiological presentation an EMS provider will face on the street.
The complexity of saving a life outside the hospital requires constant reevaluation of our evidence, our training, and our clinical tools. There is still much to explore regarding how medical directors can better support these providers in the field, whether that's through advanced simulation, as you suggest, or by rethinking the scopes of practice entirely, as the trial data points toward.
The debate is far from settled on the street, that's for sure.
Which brings us back to where we started. When that pilot is flying into the hurricane, you don't just want them to have the best theoretical understanding of the controls. You want them using the instruments that give them the highest probability of actually bringing everyone down safely, even if it's not the exact landing they originally trained for.